So we move on to our next topic. When it comes to cancer prevention, there are various biomarkers which can help in early detection. It can help in identifying inflammation early in the body. Understanding which markers are those and when they should be done can help a lot, to every healthy individual. So we have our next speaker, Dr. Arjun Dang, who will be talking about crucial diagnostics in cancer prevention, the right test timing, and lab for early detection. Dr. Arjun Dang, he is a partner in Dang's lab, and Dang's lab has brought forward very crucial diagnostics available in India. Today, Dr. Dang is not able to join us in person, so he has shared his presentation in a form of a video to discuss on this topic.
Hi, everyone, and greetings of the day. Firstly, before I start, I would like to thank the organizers for today's online meeting. And also, a big thank you to IAFM for giving me this opportunity. So, this particular topic that I'm talking on today is not only very fascinating, but is also very impactful. I have had the privilege of working with cutting edge technology in real life case scenarios where I've seen a lot of these diagnostic modalities add a lot of value to patients. And although this topic is extremely vast, I will try to touch upon the basics and happy to then address any questions over email or if anyone has any comments on my slides. So broadly, before we start, I will quickly go through what all I'm going to touch upon in today's presentation. We'll start with a quick introduction going on to serological biomarkers. Then we'll talk a little bit about cytological and histopathology diagnosis of cancers. And then we'll also delve into molecular diagnosis, immunohistochemistry, frozen sections. And then, of course, a little bit about the genetic testing for oncology as well. So, as you see on this slide, we see a lot of significant wonders of the world, like we call. And a lot of you would be able to guess which ones these are, and basis that also the city or the country that they're located in. Now, why I started with this slide is because diagnostics for oncology actually work in a very similar fashion. And when we talk about this, these diagnostic markers are actually nothing but various proteins that are detected in cancer patients and are found in your peripheral blood or in lymph nodes, in bone marrows, or even when we do biopsies of solid tumors and sometimes body fluids as well. So before proceeding, everyone would already know, but cancers are broadly divided into sporadic and hereditary cancers. When we speak about sporadic cancers, a majority or a lion's share of cancer cases are sporadic in nature, and these are essentially acquired rather than inherited. Whereas hereditary cancers, again, which make up about 5 to 10% of all cases globally, are usually inherited from either of your parents or your previous ancestors. Now, in this case, broadly, when we look at the clinical scenario in hereditary versus sporadic, the age of diagnosis is usually younger in the hereditary cases rather than the sporadic forms. Also, in a lot of cases, we see that multiple family members have the same or related type of cancer. And of course, these are multifocal in nature also, not all, but in majority of the cases. And sometimes these might also include any rare cancers that are hereditary in nature. Again, for everyone to understand, 90% of cancers that are sporadic or majority of cancers that are sporadic, these take time to happen because these accumulate mutations over various time periods that eventually evolves into malignant cells. Whereas when we talk about hereditary cancers, there are only a small proportion. These already start out with one mutation. That is, the cells involved in this already start out with one mutation. So then again, the cancer is more likely that it comes at an earlier age of presentation. So quickly going on to the widely used, and I'm sure a lot of you in your clinical practice or otherwise would have seen the utility of these serum blood markers as well. The way these serum markers are used obviously depends case on case, and we'll also discuss a few cases where these have been used very effectively. But broadly, for you to understand, these can vary from screening purposes to actually diagnosing a targeted cancer or a malignancy to monitoring the therapy and also to see if there is any kind of recurrence or any residual cancer. Also, when it comes to prognostic and theranostic purposes, these serum markers play a very critical role. So, I know this seems like a very complex overview of the various serum markers that we have today. But what is very important to understand is that the clinical correlation, whenever you're choosing to do a particular serum biomarker, is extremely critical. And that's why a detailed history, along with the other investigations, the radiological investigations again, which I'm not going to touch up upon on this presentation and has been covered in another session, I think is extremely critical so that we can have targeted testing and that can lead to a more conclusive diagnosis. So before we start discussing more about biomarkers and a few cases, it's very important to understand that it is critical for us to actually assess the sensitivity and the specificity of any biomarker. Now, when we talk about sensitivity, it's basically the true positive test results, or in other words, the proportion of tumor cases who test positive and are actually positive when their result is higher or not within the range, or in other words, and have an elevated value. Ideally, in the utopic world, a marker should be 100% sensitive. That would mean that everyone with cancer should have a positive test. But of course, that is not the reality. And I'm going to touch up on this a little bit more once we discuss the case series as well. So when we talk about specificity, it is basically those cases that have a true negative test result. So that basically means that any marker with a lower specificity means that more the non-cancerous patients will test positive. So of course, this leads to a lot of false negatives, and this is definitely not something that we would like in a serum marker. And this differentiation and understanding of sensitivity and specificity is extremely important. Again, just to clarify, specificity basically means anyone who has a true negative test result. So this is very critical along with understanding the sensitivity of the marker as well. So again, in this small chart, we see that very commonly used screening tests, that is PSA in males, has an extremely high sensitivity. So this means that if there is someone with an elevated PSA value, that could indicate that there is prostatic cancer. And hence, this is obviously used as a very effective screening tool. But also, what is important in these cases is to actually understand and utilize free PSA. That is another component or another parameter that is found along with total PSA. And the ratio of the total and the free PSA actually guides the clinician on how to proceed, or in other words, what is the probability of the patient having a malignancy in this case. So again, commonly used markers can be used from germ cell tumors to colorectal cancers to a wide variety of cancers such as breast, ovarian, prostate, even certain neuroendocrine tumors have very effective and useful markers as well. So again, going to the first case that we saw in our clinics was a 35-year-old healthy male who had a history of cryptorchidism, and that was repaired when he was a child. And he's now presented with painless enlargement of the left testis. And an ultrasound examination revealed a soft tissue mass without a cystic component. So my question to all of you is that out of these five options, which one would you choose? Would it be an AFP, HCG, LDH, or all of the above, or none of the above? So the answer is all of the above. We'll be testing all these various biomarkers. And essentially, in this case, if you see the serum HCG and the serum AFP, which were both significantly elevated, obviously persuaded or convinced the clinician to go in for a radical procedure, and that was a radical left orchiectomy. And these are the histopathology figures that we saw in the case that you can see here. And it was eventually diagnosed as a germ cell tumor with the help of these three markers. These three markers not only help with diagnosis, but also for follow-up once a person has taken the treatment. Again, this is a bit about beta HCG. I know everyone's familiar with this particular test or biomarker being used to diagnose pregnancy. It is found in few other benign conditions as well. But in germ cell tumors, again, it is a very clinically relevant marker that we use. Again, AFP also supported this diagnosis, and similar to any other marker, this can be found in certain other conditions as well. And that's why I will repeat that clinical correlation in the case and the histopathological correlation and the radiological correlation is extremely critical for us to come to a diagnosis. This is again the elevation of both AFP and beta HCG in germ cell tumors, and that's why also I wanted to stress on this slide that it's never a single marker that will lead us in the right direction, but it's a combination of markers that should be used. So this is the second case. This is a lady, a 52-year-old lady who presents with vague abdominal pain and a feeling of fullness. And she had a 10 centimeter left adnexal mass that was easily felt. And which of the following markers would you proceed with in this case? Was it a CA 125 or a PSA or a CA 27.29 or a pap smear or none of the above? So this is an easy one. The answer is A, and it is a CA 125. And also there was ascites that was the fluid showed a positivity for malignant cells that you can see on the bottom left of the screen, and then post which a radical surgery was performed, and the histopathology pictures are on the right side of the screen. So CA 125, again, very important to understand, when significantly elevated can indicate ovarian carcinoma along with few other cancers also that are written here. And there is a particular cutoff also that clinicians use as per latest guidelines. And CA 125 is extremely useful in such cases. But again, it's very important to understand in this case to rule out any kind of associated inflammation that the patient might have in these organs, because that can also lead to borderline elevations. And of course, if it is significantly elevated, we have to clinically correlate it and also look at the radiological findings in order to chalk out the next steps in the management. So, coming to the third and final case, this is a 63-year-old male who presented with urinary hesitancy, frequency, and nocturia. And a DRE was done, and the findings were a large nodular and rubbery prostate glands with some hard regions. Now, prostatic biopsies were also performed, but before that, I would like to ask you which is the most useful marker. Now, in this case, of course, looking at the primary organ as well, looking at the findings of the DRE, a PSA test is something that will always be recommended in such cases. Again, what I told you about the total and free PSA is also extremely common. What you must remember as a thumb rule, although this might vary from lab to lab and test to test, but the free PSA component, if it is less than 25% that of the total PSA, that might indicate a higher chance of the person having prostate cancer, whereas a high free PSA level also is a sigh of relief and might indicate something like a BPH or prostatitis or any benign condition that is causing the total PSA to increase. So again, in this case, we did a radical prostatectomy. The pictures from the histopathology are on the extreme left and extreme right side of the bottom of the screen. Also, the Gleason score was 7 in this case, that is depicted at the bottom of the screen. Again, for us to understand PSA, this is an extremely sensitive marker for prostate cancer. There are various guidelines that suggest PSA to be done beyond a particular age in elderly men, probably above the age of 50. And in these cases, we have to rule out BPH because that is also extremely common. And of course, along with the DRE, also and other findings that must be correlated before we come to a final conclusive diagnosis. So, broadly, from a serum biomarkers perspective, we must understand that clinical correlation is critical in these cases. Screening markers can be PSA, these can also be few other screening tests that are also employed, although not biomarkers, but these are pap smears along with an HPV DNA for female patients. But again, all of these can also be biomarkers, can be used for various staging, prognosis, follow-up purposes. And a few examples of this is given on this slide. So as we proceed ahead, um, I just want that when you are ordering a serum tumor marker, there are few points that you must keep in mind. The first one always is that never rely on a single test. It has to be a panel of serum markers that help you rule out and also confirm the diagnosis or the differential diagnosis so that you can plan next steps appropriately. Also, it's always very important that we rule out any other associated disorders or any kind of associated inflammation that might be causing this increase. And definitely a detailed medical history with what medication, supplements, etc., that the patient is on should be taken. Also, for serial testing, when we are trying to monitor any of these serum markers, it's always important to stick to the same lab so that they're using the same machine and the same kit and the same methodology, and more importantly, the same reference ranges as well, so that it's easier to make an apple to apple comparison. And also, of course, I have repeated it multiple times that clinical correlation is key. And in certain biomarkers, there can be certain medications as well that can cause an elevation. For example, the widely used and extremely advanced biomarker known as PIFCA for HCC again shows an elevation if anyone is on any kind of vitamin K antagonists like warfarin. And that's why that history is very important. Similarly, for biomarkers such as chromogranin that is done for neuroendocrine tumors. A lot of times we see there is a lot of anxiety in the patients, and the doctors also plan for something radical, but sometimes it's just because of chronic PPI use. So we should be very careful of that. Okay, so moving ahead now, going on to psychological diagnosis that primarily includes what we call as FNAC, that's a fine needle aspiration cytology. This is most commonly done for suspected thyroid lesions, lymph nodes, and also to rule out breast cancer. And this again is a very old and traditional and effective technique as well. And that is used for anything that is palpable to the naked eye as a outpatient procedure. But whenever the lesion is not palpable, then we go for ultrasound or CT guidance to get into that particular lesion and then draw out the cells that need to be studied under the microscope. So coming to histopathology, histopathology obviously is the gold standard for any kind of conclusive cancer diagnosis. For doing histopathology, that is studying the tissue, a biopsy is done. This biopsies of various types, as you can see on this slide. And sometimes an excisional or an incisional biopsy is also done, depending on the level of suspicion and the other investigations that have been done in the case. So frozen section is again something that's very interesting. Frozen section is essentially when a patient is on the operating table and the surgeon is not sure whether the lesion that he's dealing with is malignant or benign. And that is in real time, in a very short turnaround time, they send a tissue to the histopathology lab. And using a cryostat, the particular tissue is frozen and made hard, and then it is cut, and then a slide is made and stained. And within a few minutes, the pathologists give the diagnosis of either it being malignant or benign. That guides the surgeon ahead appropriately. Now, going on to diagnosis more related to hematology. Now, in these cases, what we basically look at is leukemias, sometimes even METs from lymphomas or solid tumors. And bone marrow aspirate is usually done as the first line, in which again the number of blasts and the number of cells of different lineages are identified as per the morphology. And then also flow cytometry, that is again a very critical way of analysis, is used for bone marrows and even on peripheral blood that helps us to a more conclusive diagnosis. Basically, this involves gating various kind of cells with various CD markers, and then basis this we can predict the origin and the lineage of the different cells, and then guide the hematologist accordingly. Again, coming to molecular side of diagnosis in oncology, immunohistochemistry, that is a step to your
Ja,
routine
Dr.
diagnosis,
Ari,
is something that is extremely important. Immunohistochemistry, again, why is it so important? Because it not only helps with diagnosis, but also to see how the disease is progressing, that is for prognosis, and then most importantly for theranosis as well. That means that how to treat the particular tumor. So when we talk about diagnostics, I'll give you a simple example of cytokeratin. And cytokeratin is simple immunohistochemistry that is done post histopathology to differentiate if the particular cancer is a carcinoma, or are we looking at some other type of malignancy. Then you also have, in the case of breast
So I
cancer,
do not know if they see me
B and
now.
other malignancies, when we see the number of P63 stained cells, and this basically tells us that the number of mitotically active cells that are there in the particular tumor, and that helps for staging. And then also, again, with breast cancer, I'll give the example of ER/PR and HER2/neu, and these are basically estrogen receptor, progesterone receptor, and HER2/neu that basically guides the clinician if there are any kind of specific treatments that would be effective in these cases. And again, so very important to understand that IHCs are very critical in all the three stages of diagnosis, prognosis, and purposes of therapy as well. So this is again a Ki-67 uh, staining that we show here. A and B are the histopathology slides, and then Ki-67 that again shows the mitotically active figures in this particular tumor cell microscopy that you're seeing here is again a very commonly employed IHC that we use. So coming to the latter half of the presentation where I'd be talking about genetic testing for cancers. And this is a banner image from a, genetic testing site. And this basically talks about how the future of your health is in your genes. And how does cutting edge technology today enable us to study these and then decipher the diagnosis more effectively. Very important to understand that the human genome consists of 3.2 billion bases, but the protein coding genes only make up about 1.5% of the entire genome. Now, when we think of genetic testing, it's very important to understand the benefits and the limitations also of genetic testing. Obviously, the benefits will be that you can better understand your cancer risk. Even family members of someone who is a cancer patient can understand their potential risks, and then the doctor can guide them about the appropriate screening frequency or if they suggest anything else moving ahead. Also, looking at the flip side and the limitation, sometimes these tests are extremely expensive, sometimes the interpretation is extremely complex, so you need a genetic counselor as well. So we must keep that in mind too. So again, we must understand about what are broadly cancer genes and what kind of mutations happen in these. Mutations in these cancer genes, again, how I explained in the beginning of the presentation, can be somatic or inherited in nature. And also, cancer genes are of two types: tumor suppression genes that normally function to prevent the cell growth, whereas oncogenes normally function to promote the cell growth. So, any kind of mutation in these genes can flip the normal physiological process, leading to a cascade of events that can then lead to a malignancy being diagnosed. So again, when we talk about tumor suppressor genes, the very common example of this is BRCA1 and BRCA2 that we are going to talk about later as well, that is related to breast cancer. And oncogenes such as the RAS family of genes is something that we see very commonly. Also, there are certain DNA repair genes as well, and these can also be inherited or acquired. Again, very interesting, and I wanted to make a mention of this, is that some cancers are associated with certain viruses as well. For example, the widely known cervical cancer in women, and a majority of these, close to 95%, are infected with human papilloma virus. And that's why now a pap smear and HPV screening, that is the HPV DNA testing, is very important. And also for HPV 16 and 18, that are the most common culprits in the case of high risk cervical cancer cases. So again, it's very important to understand that genetic testing or which kind of testing you are doing is dependent on the particular primary also that you are looking at. For example, with prostate cancer, like I said, total PSA and the free PSA and their ratio is very useful along with a digital rectal examination as well. But obviously, sometimes it is worth testing for to understand if the patient has any inherited mutations and also to understand the cell molecular genetics and how the cancer is actually going to act. Is it going to be very aggressive or not? So, this is also something very important. Similarly, for lung cancer, again, it is extremely important for genetic testing to guide us. For example, you test an EGFR or an ALK and other things to understand which is the proper drug or which is the proper chemotherapeutic agent that should be given to the patient. Again, with breast, again, there are multiple examples, but genetic testing is extremely critical, especially in cases where we are looking at the BRCA gene. And like all of us already know, BRCA1 has a close to 60% chance that if someone in the family has it and has cancer because of it, another family member has a very high probability, whereas BRCA2 also has a close to 40% probability. So in these cases, it becomes extremely important. Also, the very famous story about Angelina Jolie and how she got diagnosed with the BRCA1 gene mutation, and that gave her an extremely high probability of developing ovarian and breast cancer. She also had some family members who had the same diagnosis, unfortunately, and she underwent a prophylactic mastectomy and oophorectomy. And you can just see on the bottom left the amount of awareness that this generated. But then again, in these cases, it's very important for an expert or an oncologist to guide you regarding the probability, a genetic counselor to explain to you what are the possible options and what they recommend for you. Because obviously, in a lot of cases, this can also cause a lot of anxiety. So it's very important to understand.
Okay. Thank you, Dr. Dang, for that, for the wonderful insights.